So we're going to talk next about the hepatic system. The liver has several functions. As you know, the liver stores iron in utero. A baby born at full term will have iron stores to last 4 to 6 months. Okay. Breast milk is low in iron, but the bioavailability is better than formula. So even though it's low in iron, the infant tends to absorb more of it. Okay. At birth, when the cord is either cut or dries, the newborn loses the maternal glucose supply. So that means the infant needs to eat soon. If the infant has an elevated insulin production because the maternal blood glucose was high, or if they don't have adequate intake, or if their intake is delayed, they don't eat soon, or they don't eat enough, or if their glucose use is higher, if they're using more energy, any of those things can lead to hypoglycemia. So I think you can probably start to put some of those pieces together. If they're working harder to breathe, they need more glucose. Also, it may make it harder to eat because it requires energy and oxygen to eat. So that's a greater risk. If they are using energy to stay warm, they're going to require more glucose. So think about all the things that can affect blood glucose. So the infant has to eat relatively soon. We want the baby to be eating within a couple hours after delivery. Typically, in nature, a healthy baby would be nursing probably pretty soon after delivery, and that has some effects. It also decreases postpartum hemorrhage for the mother. There are a lot of cases, though, when that's not possible because of a complication for one or the other. We're going to talk also about bilirubin and jaundice. You hear a whole lot about babies that are jaundiced. So we're going to talk about what contributes to physiologic jaundice and then what might lead to pathologic jaundice. So the liver actually conjugates bilirubin to allow for it to be excreted. That's why your adult patients with liver disease get jaundice, because they cannot convert that to a water-soluble form for excretion. Indirect bilirubin measures unconjugated bilirubin. That's how much bilirubin is there that they cannot change to a water-soluble form to be excreted. Direct bilirubin measures conjugated bilirubin. Now, the liver requires the initiation of feeding to be able to become efficient at conjugating bilirubin. So the liver requires the baby to be eating fairly well to be able to efficiently conjugate bilirubin. In the first few days of life, until the serum albumin level goes up because they're getting some food in, there actually are fewer binding sites for bilirubin. There are some things that increase bilirubin levels. If the baby has a lot of bruising from delivery, that's going to be more red blood cells to break down right away. If the baby is premature, the liver's not going to function as well. They're not going to get food in as early. They're not going to have as many binding sites for a bilirubin. If they don't pass meconium within the first 24 hours, or if it's passing slowly, then that bilirubin can be reabsorbed. If they have a higher red blood cell count at birth. So if a mother is diabetic, and there are some other things that would cause this, but this is one of the effects of diabetes on the fetus will actually have even more red blood cells. And remember that babies are born with more red blood cells than we have in relation to their size, but diabetes causes that to be even higher. So when those break down, that causes increased bilirubin. Delayed feeding, because we can't conjugate that bilirubin until we get some food out. And also delayed feeding tends to make the gut more sluggish and they don't expel the meconium as early. Pathologic breakdown of red blood cells. And this is where we get into pathologic jaundice. If the red blood cells are being broken down abnormally, say in the case of maternal antibodies against that baby's blood type, that will cause jaundice. and infection, because infection can cause breakdown of red blood cells, but also delay the conjugation. So physiologic jaundice is very common. It occurs after 24 hours. It usually does, bilirubin levels usually don't reach higher than 15 milligrams per deciliter. And it's usually self-limited. Pathologic jaundice, the levels get higher. Bilirubin levels greater than 20 milligrams per deciliter are associated with damage to neurologic tissue, because that bilirubin becomes gets deposited in neurologic tissue. It's called kernicterus. So greater than 20 is associated with complications. Pathologic jaundice is most often due to an infection, a genetic disorder. Sometimes it can be a liver disorder, or hemolytic disease of the newborn, which is the most common cause. And that's when the mother's and the baby's blood types are incompatible. There's been some exposure, because remember, they're not supposed to cross, but sometimes they do. And the mother has antibodies against the baby's blood type, which causes those red blood cells to break down early. Jaundice that appears in the first 24 hours is always, always, always a red flag. It needs to be addressed. There are a couple of other types of breast milk that jaundice that you need to know about. You'll hear about breast milk jaundice, and you'll hear about breastfeeding associated jaundice. Those are not the same thing. Breast milk jaundice is a variation of physiologic jaundice. The fatty acids in breast milk actually compete for binding sites with the bilirubin, and that slows down the conjugation of bilirubin, and so bilirubin levels go up. That can usually be treated by stopping breastfeeding for like 24 hours and then restarting. But it's considered a variation of physiologic jaundice. Breastfeeding associated jaundice is related to poor initiation of feeding. Either the baby is not able to nurse effectively, which can happen sometimes with a premature baby or a baby with some other complications, or the mother is not able to produce adequate milk early enough. And that is the cause of breastfeeding associated jaundice, is decreased binding sites and dehydration. Okay. So don't get those mixed up. They're two different things, and they have different effects. The liver also affects clotting. It synthesizes coagulation factors, but that requires vitamin K, which is synthesized in the gut, which requires intestinal flora. And so at birth, the baby's not making their own vitamin K. We give a vitamin K injection to the newborn, just until they can make their own. Some signs of hepatic problems. These are some things in your assessment that if you see these, you need to address. Hemorrhage, hypoglycemia, jaundice in the first 24 hours, extremely high bilirubin levels. Okay, the next section, we're going to talk about the immune system.